Such a bad day. Oh. Oh, okay. I thought maybe I had like this hectic day. Oh, okay. All right. Let's not tell management about that. And then, oh, sorry, this part was supposed to come out. I don't know how it got left on. So we're going to analyze this ECG today. Forget about this history here. This was from last week. I just forgot to take it out. So actually this week, we've got a 54-year-old woman complains of mid-sternal chest pain and lightheadedness. Right. So of course you are going to, oh, thanks, everybody. And so of course you are going to do an ECG for this patient. I mean, but like I always say, imagine now you were sleeping in the car, you know, and they call you and you start hearing mid-sternal chest pain and lightheadedness. So what's your differentials for chest pain? That's what I'm asking, you know. So number one on top of the list, of course, would be MI. All right. What else? Because chest pain is not only MIs. What else can it be? Any idea? Some that
pericarditis, osteochondritis, esophagitis.
That's true. I've got Dr. Ricardo in my ear as well, so he's giving me a few. But I want to hear from the guys in front of me as well. 1 second. Let me change this to morning. How are you? Hope it works now. Ricardo, can you say that again?
Yes, there is a few differential diagnoses like
Dr. Ricardo, can you just say those again?
Yes, sir. Can you hear me?
Hello. Okay, now neither of us can hear him. Okay.
Hello.
I think I asked too much. But you mentioned esophageal conditions, costochondritis. Anything else that you'd worry about?
Anginas.
Yes, angina, MI. Yeah. Anything else? Respiratory causes, the lungs. What else in the lungs can give you mid-sternal chest pain and lightheadedness? Can kill you too. Pulmonary embolism, very good. All right. So those are the two that have to be at the top of your list. Anything else with the lungs that causes pain and lightheadedness? Especially if your lung pops, pneumothorax, things like that, you know. So you got to think of it broadly, all right? But of course, when you walk in there, you're not going to go and check for what you might call it, Mallory Weiss tear and all of that. You're first going to go and do an ECG, all right? So let's analyze the ECG. Okay, sorry, and just all right. So now let's look at it. So if you guys can't see it properly there, you're more than welcome to come and check it on the screen here as well. All right. And just turn it a bit that way. Is that a bit better? Okay. So yeah, so let's start first. So we always start with the axis. All right. So for the axis, we look at lead 1 and lead AVF. Let's draw it out here a little bit. All right. So let's draw. So imagine we've got our 4 quadrants. All right. And then we've got, this would be normal, left axis, right axis, extreme right and right. Here we've got lead 1, and here we've got lead AVF, right? So which way is lead AVF, lead 1 pointing? Upwards or downwards? Upwards. Agreed. So that means electricity is moving towards lead 1, all right? So if lead 1 is here looking at this quadrant, that means either that's there or there. All right, so we've either got a normal axis or a left-sided axis. All right, we've already discounted these two. And like I say, you can use any method. This is just a very visual method of seeing it. All right. Okay, so we know for sure we don't have a right axis or a extreme right axis. Now we look at lead AVF. Which way is lead AVF pointing? Difficult to say, isn't it?
It's mostly negative.
Mostly negative, but when you look at this one, it's almost like biphasic. Agreed. Okay. So
yeah,
what?
biphasic.
Yeah. So what does biphasic mean? So when a lead is biphasic, what it means is that electricity is traveling perpendicular to it. So when it's positive, if you can imagine the lead sitting here, it sees electricity coming towards it for a while, and then it sees electricity leaving for a while. So when it's seeing the electricity coming towards it, it puts a positive deflection. And when it sees the electricity moving away, it gives you a negative deflection. So in other words, lead AVF is basically seeing electricity moving along this line, all right? But in which direction, to the left or the right? because we discounted movement to the right already, it's basically moving almost exactly on that line, all right? So it's within normal, okay? Because up to, they say minus 30 degrees here is still regarded as a normal axis, all right? So we've got a normal axis, very good. All right, now the rhythm. Haha, let's start. Can anybody see P waves? Atrial pulsations? You can, isn't it? But they're very tiny. All right. They're extremely small, actually. They are there. So is that normal? It's not normal. It's not normal. All right. Your P wave should be well defined. You should be able to make them out easily. But at least we can see them. All right. They are there, even though they are small. So already they should start getting your mind thinking, all right, what's going on? Now, what about the PR interval? The PR interval is about 2 to 2.5. So it's borderline. All right. Borderline fast. Okay. Borderline fast. Our QRS complex is narrow or wide? They narrow. Does the QRS follow every P? Yeah, it does. Yeah. Even though the P's are difficult to see, but they are there. And are those groupings regular? Yeah, it's a bit of sinus arrhythmia, but in general, it's regular. All right. So let me ask you, so we already know the PR distance is very short. That means from the time of the atrium contracting to the ventricle contracting is very short. So what would you expect your heart rate to be in those circumstances? Because your atrium is not taking much time. I mean, if you had such an abnormality, would you expect a slow heart rate, a fast heart rate? What would you expect? Just thinking about it, considering there's not much time between the two, you kind of consider more of a fast heart rate should be coming about, all right? So it's quite strange because your heart rate here is not very fast, like 1, 2, 3, 4, 5, 6, 7. What's 300 divided by 7? Anybody knows off the top of their head? It's quite slow. I think it's about 60 somewhat, all right? So in other words, that is a bit strange. Even if you don't know exactly what's going on, but it's already a bit strange. Number one, the atrium and the ventricle are passing signals along too quickly. And even though that signal is going along too quickly, the heart is supposed to react very fast as well. It's not. It's actually just carrying on at a normal pace. Okay, so I mean, actually a slightly slow pace. So there's something going on. But in any case, even if you don't comment on all of that, that wasn't the main thing, all right? Even if you could just say something looks abnormal, that's fine. Now we get into the meat of it, all right? So we're going to look at a zone. Which zone would you guys like to look at? Does anybody know the zones? Aha, nobody's watched those videos yet, I can see. Yeah, are you sure? All right. Hey, inferior. All right, let's look at inferior. So which one are our inferior leads? 2, 2, 3, and AVia. Very good. And what do we notice? Hey? ST depressions. Very good. It's okay. Don't worry. You won't answer wrong. Just answer. This is not a lecture hall. Don't worry. All right. Even you rather ask, and then I can tell you, all right, this is why it's not, this is why it is. All right. But what we can see, so that's the zero line. All right. So the zero line is where there's no electrical activity like here. All right. So the zero line, the ST should be in line with that. All right. So anything above that line, ST elevation, anything below, ST depression. All right. So these are all ST depressions. Okay, so we know that we're not stopping there. Now let's look at other things. All right, let's look at the right side of the heart, AVR. What do we notice over there? Also, it's okay. You can speak softer. Don't worry. ST. Yeah, very good. ST depression as well. Yeah, that's very good. And then, all right. So we look at 1 and AVR now, which are high lateral leads. All right. And what do we see there? ST elevations, very good. So already where is our mind going? Where is this infarct starting? Starting in a high lateral, all right? And we've already got reciprocal changes, okay? We've got reciprocal changes that are going on. So even before we look at the chest leads, we already know this is a myocardial infarct. Now the question is, how far has this infarct gone? So let's look at our septum, all right? V1 and V2, what do you notice? Very good, ST elevations, all right. So these ST elevations, are they low or are they high? Quite high. Eh? Even this one here too, you notice it's quite high. Let's look at the anterior of the heart, V3, V4, and what do we see? Very good, ST elevations. Then if you look at V5 and V6, which are, like I say, in combination with 1 and AVL, just that they're looking more at the lateral edge rather than the high lateral edge, what do you notice there? V5 looks relatively normal. V6, actually a slight, what does it look like? Actually, it looks like a slight depression. Agreed. If you really look at it, it's come down a little bit, yeah? Not by much, but like a block or so, but it's down, all right? So that may be how the lead is placed. It may be something like that. All right, very good. You know you've got a myocardial infarct. Where is your myocardial infarct now based on all of that information? You've got anterior, septal, and lateral. So what are you going to tell the physician that's coming now? Anteroseptal, right, is a common term used. So you can say I've got anteroseptal plus high lateral extension. All right. So how much of the heart are you looking at in terms of those three zones? Is a small piece of the heart, big piece of the heart? Big piece of the heart. All right. It's a massive piece of the heart as well. All right. Almost the entire left side is completely involved in this process. Okay. And just as a general rule, the higher your elevations, the more of the wall is involved, the worse the infarct is. All right. So if you had, for example, just 1 or 2 blocks compared to here, we've got almost 8. 1 or 2 blocks is not as bad as 8. All right. Just as a general rule. All right. So are you going to go out and have coffee now? Yeah. What are you going to do now? That's the question. How will you treat this patient? Eh? Right. Go step by step. Right. So one thing, we're going to give them oxygen. Right. We need to give them as much oxygen as possible. What's the next thing we need to give them? Morphine, how much? Okay. It's about 5 milligrams. All right. Like I say, some areas are using tranquilizers. We still use morphine. Morphine is a tranquilizer. Why do we use morphine though? Why not use pethidine? Why not use tramadol? They're all opiates. Why not? Any idea? Any idea? Or why use a tranquilizer, for example? All right. So the thing is, all right, the first reason why we don't use pethidine actually decreases right ventricular function. All right. Now, if push comes to shove and you don't have morphine available, you can use pethidine, but it causes your right ventricle just to contract a little bit less. It also is not very good for the kidney. So if you've got somebody in renal failure, it's not a good drug to use. All right. So you've got this option of morphine. Has anybody ever had morphine, like pre-op, post-op? Anything like that? It's a wonderful drug. I've had it. It was amazing. Honestly, I'm telling you. The best part about it was that I remember when I went here, when I had it recently because of my back. All right. So I was screaming in pain and I went into the hospital. They gave it to me and I chilled out immediately. My heart rate and respiratory, my heart rate was about 125 with the pain. My respiratory rate was over 35. As soon as they gave me the morphine, heart rate came down to about 80. Respiratory rate was about 12 because I was calm now. I wasn't in pain. So what happens to a heart that's damaged and is beating fast? What does it need in order to beat fast? More blood with more oxygen. And what is it not getting? Blood and oxygen, because there's a blockage. So in other words, by letting this heart continue to beat fast and use a lot of energy, you're actually making the infarct worse. You get what I mean? So that's one of the reasons why we use morphine, or as I say, tranquilizers in certain centers. Okay. Now, what else do you need to try and do? Do you need to try and get blood and oxygen to that area? How can you do that? Very good. Aspirin, right? Very good. TNT, and you said the other one, clopidogrel. All right. So all three of those combine to try and create a little pathway, all right, through vasodilation, clot dissolution, what you call it, fibrin breakdown, all of that. You're trying to get the blood into that section. All right. And then what do you do? What else do you need to do for this patient? Not in terms of treatment, but investigations. Very good. Cardiac enzymes. D-dimers, very good. Clotting profile, FPC, UNE, CRP, and an ABG. All right, those are your baseline studies. How long are you going to wait to call the physicians? Exactly, yeah. So by the time they come in, you've already done everything, right? Because this is a serious one, all right? So this one here is actually close to something that they call a tombstone MI, all right? So tombstone MIs are when basically the ST segment and that wave, the T wave combine, all right? So there's two reasons why they call it tombstone. It does actually look like a tombstone and it tells you about the prognosis, all right? So this is very close. No, I didn't come up with that, all right? So it's quite a serious thing. All right. So why I've concentrated on infarcts for the last 2 days is because I noticed some of the guys were having a bit of problems just just to get us back into it. All right. So let's have a look at the answer over here and see what we've got. So the lightheadedness may be due to low BPs and things like that. All right. So we'll try and stabilize this patient as much as possible. All right. So we're already according. So this is you remember we were talking about how it looks strange, the PR interval and all of that. I don't want to get into this now, but this is a variation of something we call a junctional rhythm. Now, those who are following from last year, we covered junctional rhythms, in which we said this, normally no P waves. This is a very special, not a special case, but it's one of the cases where we do get P waves with the junction. I don't want you guys to worry about that now, right? So the rate was actually 50, not 60. So she was borderline bradycardic, all right? So acute anterior, anteroseptal, and high lateral myocardial infarction, all right? So this is basically explaining the junctional rhythm, but like I said, I'm not too worried about that in this. So ST elevation is present, mid-precordial leads leading to the diagnosis of anterior wall infarct. ST elevation also present leads 1 AVL, corresponding to the high lateral wall of the left ventricle. All right. Reciprocal ST segment depression is present in inferior leads. The presence of reciprocal changes significantly increases the specificity of ST segment elevation for an acute MI. So you guys did quite well. Right? So you'll diagnose the MI, you'll know how to treat it in the emergency room, and you know how to investigate it. What would be your treatment now? Beyond that, let's say you're also going to take the patient to ICU or something like that for some reason. What are your treatment options for this patient? There's only 2 treatment options. Sorry? Very good. So PCI, all right. So percutaneous coronary insufflation, all right, or stenting. Recently, I was speaking to one of our local physicians, one of the private guys. He was actually saying that they're moving away from stenting now a little bit. It's still common, but they're moving away from it because essentially you've got a foreign body introduced, and they've actually found that the inflammatory response to that sometimes can be worse than the original blockage. So they're trying to move away from it, but it still works. Not to say it doesn't work. So don't, if one of you has a heart attack, please don't go to hospital and say, don't stent me. I'm not saying that. And what's the other way that we can treat it besides PCI? Coronary bypass, definitely you can. But you must remember coronary bypass takes a bit of planning. So I'm just saying, what can you do immediately to try and help? They had to do it. Where did they do it? Here in ICU? Yeah. Okay. They thrombolized with the CVP. Huh? Who did that? Okay, if they use it, no problem. Oh, okay. Yeah, all right. That makes sense. Wow, you're lucky. Yeah. Okay, no, that's good. They're using streptokinase at the moment, or the alteplase? Yeah, okay, no, that's fine. But thrombolysis, that's the other thing. No, I'm just saying, like, normally, but if you're doing a femoral CVP, it's fine because you can compress a femoral CVP, all right? But generally, you won't thrombolize if you've got a subclavian CVP and things like that, because you can't compress, but a femoral CVP, you can, all right? So thrombolysis can take place within 30 minutes, all right? And you'll save the patient. Or within 90 minutes, you can do PCI, all right? But how long did it take you all to get the patient thrombolized? When the patient got here, we notified the so she was now in about 30 minutes. Okay. Wow. So you guys are having fun during the day, man. That's cool. No, but that's excellent. That's excellent. Yeah, okay. No, once you get it, post it on the group because it's interesting. Post thrombolysis ECGs, if you look at them, you'll think the patient's having another MI. Agreed. It looks so strange. It's a wide, complex ECG that actually looks worse than the original ECG in some cases. All right. So you'll post that on the group once you've got it. And that's just a joke to finish off. All right. So what we'll do next week is that I'm going to have, instead of covering an ECG, we're going to cover chest pain. All right. So just to give you guys an idea of how to approach chest pain. All right. From the point of view of a cardiac patient, but what else could it be? What do we look for? How do we categorize patients? Things that you need to look for besides what we've been looking for on this ECG and things like that. All right. So hope you guys will come for that as well. Any questions? Anything I want to know? Seriously, every week there's no questions. I don't know why. Everybody just wants to bugger off. Thank God he stopped talking. Okay, nobody has no questions. It's fine. Then I hope you learned something today. And like I said, next week we'll cover just chest pain on its own, right? The differentials, how you look at it, right? Dr. Ricardo, are you okay?
Yeah, thank you, sir.
Okay,
yes,
no problem.
yes, yes.
All right, so we're going to end it there for everybody. And then, meet again next week.